I'm Dr. Shahid, ER specialist. Today we are going to discuss the status epilepticus. First of all, we'll see what is the definition. Uh, we can define it as continuous seizures lasting more than 5 minutes or two or more seizures within 5 minute period without return to neurological baseline in between. As we know, most of the seizures resolve spontaneously in 1 to 3 minutes. However, if the seizure as per defined doesn't resolve, so we will label them as status epilepticus. So what we will do when the patient is brought in the emergency department, so the initial management will be A, B, C, D, E, F, G. ABC, as we know, we don't forget it: airway, breathing and circulation. And don't ever forget the glucose, D, E, F, G. So capillary glucose must be checked. For airway, we should position the patient to avoid the aspiration, and we should try the suction, put the nasal cannula, and observe the patient. Second, we will go for the IV access and take the blood for VBG, glucose, electrolytes, including sodium, calcium, and magnesium. And if any suspicion, then must take for the medical purpose toxicology screening, and if childbearing female, then check for the beta HCG and also take the CK and must check the lactate. Then what should we do next? We must give the patient 3 milligram midazolam or 4 milligram lorazepam, and we can repeat it in 4 minutes. If possible, we can give midazolam 10 milligram intramuscular. If there is no response to the initial dose of IV benzodiazepine, then we can go forward for the starting phenytoin sodium or phosphentine, valproate, or levetiracetam. If all these pharmacological parameters are failed, then prepare the patient for rapid sequence intubation with propofol or ketofol or succinylcholine, because our aim is to save the patient for immediate life threats. Then we have to go for this metabolic parameters. We have to go for check the hypoglycemia or hypernatremia, If there is a hypoglycemia, then we have to give the glucose. If there is hyponatremia, then we should go for the hypertonic saline. Or if there is a hypomagnesemia, then we have to give the magnesium. And if there is hypocalcemia, then we have to give the calcium gluconate. In case of toxicologic, anticholinergic or isoniazid pyridoxine or lipophilic drugs overdose, in that case we should give the lipid emulsions. If the pregnant lady, then we have to go for, in case of eclampsia, and if the female is pregnant more than 20 weeks, then we have to give the magnesium sulfate 4 to 6 gram over 15 to 20 minutes, then infusion 1 to 2 gram per hour. Once the patient is stabilized, we have to go ahead for the CT scan to rule out any space occupying lesion. The first line, the treatment which we have to do with patients in the emergency department, we have very specific guidelines. So we have to, what are the guidelines? This is a time specific guidelines. That first A, B, C, D, E, F, G, then airway, put the patient in lateral decubitus, nasal tremps, oxygen, suction. Number 3, IV access. Number 4, search for reversible causes. Then within 0 to 5 minutes, we have to apply first line agents, that is lorazepam. The dose is 0 to 1 milligram per kg IV, and maximum dose is 4 milligram. Repeat once in 4 minutes, or midazolam 10 milligram intramuscular once. Here we can also give midazolam 3 milligram IV. Then if the fits are not reversed or terminated, and within 10 to 15 minutes, we have 2 options. Second line agents, which are the levetiracetam 60 milligram per kg IV, and its maximum dose is 4,500 milligram, or phenytoin 20 milligram per kg IV and maximum 1500 milligram, or valproate 40 milligram per kg IV and its dose is 3000 milligram. If it is failed, then we have to go advanced airway management, the rapid sequence intubation. In that case, we have to pre-oxygenate the patient, and then we have to induce the patient with the propofol or ketofol. We can use the paralytics like rocaccuranium if it is available, and if the seizure duration is more than 25 minutes. Otherwise, we can use the succinyl choline. If even after intubation and patient has still fits, we are calling it the refractory medication in status epilepticus. That include propofol 2 to 5 milligram per kg IV, then infusion 2 to 10 milligram per kg per hour. Then midazolam 0 to 2 milligram per kg IV, then infusion of midazolam 0 to 0.5 to 2 milligram per kg per hour. Third one is ketamine 0.5 to 3 milligram per kg IV, then infusion of 0.3 to 4 milligram per kg per hour. Fourth one is locasamide 400 milligram IV over 15 minutes, then 200 milligram 12 hour per oral or IV. Fifth one is the phenobarbital 15 to 20 milligram per kg IV in 50 to 75 milligram per minute. This is the management in emergency. If it is all failed, then call the anesthetist and prepare the patient for ICU.